In this tutorial, we'll be discussing Doppler effects. We'll be looking at the differences between peripheral and abdominal vascular evaluations. The references used for this tutorial include the Techniques in Non-Invasive Vascular Diagnosis, 3rd edition, Chapter 1 by Robert Daigle, and Cardiovascular Hemodynamics and Doppler Waveforms Explained, Chapters 1 and 2 by Crispian Oates. Okay, let's look at all the things that you're going to be able to do when you finish this tutorial. You are going to be able to list two differences in the usage of Doppler within the abdomen versus its usage in peripheral imaging. You're going to be able to choose correct angle of inclination when you're given separate situations. You will be able to match all the waveforms in the abdominal vasculature with the appropriate vessels. You will be able to correctly choose the hemodynamic explanation that's associated with high resistance and low resistance waveforms. And you will be able to list at least 3 common pitfalls encountered during abdominal sonography. The first few slides are going to be a review. We're going to talk about the Doppler effect, and that's the apparent change in frequency of a wave caused by relative motion between the source of the wave and the observer. We're going to begin with how sound is perceived. In this situation, we have our observer, a little green man is our observer, and we have the black dot, which is going to represent the sound transmitter. So when sound is created, it travels outward from the transmitter at a particular frequency. Now, frequency is the number of waves that pass a given point per second. So if the transmitter and the observer are both stationary, then the observer will perceive the exact frequency pitch that is sent out from the transmitter. Now, there's also wavelengths. I want you to notice those, and they're pretty equidistant at this point because both the transmitter and the observer are stationary. So what happens when the two objects, the observer and the transmitter, are no longer stationary? In this situation, the transmitter is going to start moving toward the observer. That would be like an ambulance with a siren moving closer to the person perceiving the sound. When this occurs, you notice that the front of the transducer, the waves seem to bunch together. Now when this occurs, the wavelength shortens or decreases, and since the wavelength shortens, then the frequency increases. So higher frequency is equal to a shorter wavelength, which ends up resulting in higher pitch being perceived by the observer. That's why the ambulance, as it comes closer to you, it sounds louder. So what happens when the transmitter moves away from the observer? If you notice the wavelengths on the back of the sound wave, they have lengthened, and then the frequency has decreased. So basically, when you get a lower frequency, you get longer wavelengths and you get a lower pitch being perceived by the observer. That's what happens when the ambulance has passed the observer and is headed away from them. So how does any of this relate to ultrasound? So in this situation, we have a transducer that's emitting a frequency. As that frequency enters the body and interacts with a red blood cell, then that red blood cell happens to be traveling toward the transducer, and as the sound intersects with the movement of the red blood cell, then an echo is produced and transmitted back to the transducer. When the transducer receives this echo, it assigns it a frequency shift. So if the object is moving toward the transducer, then remember that bunched up waveforms that we saw earlier. Same thing happens here. The returning frequency is higher than the transmitted frequency. That will give a positive Doppler shift when the machine creates a waveform. That means it's going to be an antegrade or positive Doppler shift. Here's a transducer that's emitting a sound wave at a particular frequency. It's entering the body, interacting with a red blood cell that happens to be moving away from the transducer. There's a bounce back echo, and since the red blood cell is moving away from the transducer, we remember that that bounce back frequency is going to be a lower frequency than the transmitted one. So if the object's moving away from the transducer, the returning frequency is lower than the transmitted frequency. This is going to result in a negative Doppler shift. And if you look at the equation below, you see that delta F, which is the frequency shift, is equal to the received frequency minus the transmitted frequency. So we're going to plug in some numbers just to make that make a little more sense. So let's say that the transmitted frequency was 4 megahertz and the received or bounce back echo is 2.5 megahertz. So that's going to result in a negative Doppler shift because it's going to be a negative 1.5 megahertz. So the last couple of slides, we were living in the perfect world in which the frequency that was transmitted from the transducer traveled in a parallel plane to the red blood cell, and then the received echo bounced back in a parallel fashion as well. Well, we know that's not the reality of life because, as you can see here, blood vessels can be very tortuous, which creates all kinds of angles that we have to deal with and work around. Next couple of slides, we're going to talk about the Doppler equation and the angle incidence and how those affect the measurements that we take. So the Doppler equation, it begins with delta frequency, which is the frequency shift that we've already discussed. Frequency shift is going to be equal to the transmitted frequency times 2 because it has to travel to the object that it interacts with and then travels back. And then that's going to be affected and it's going to be multiplied by the velocity of the blood cell. And then you have the cosine theta. Now this is extremely important. Cosine of the Doppler angle of incidence, and we'll look at that in the next slide and describe that a little bit better. But then all of those are going to be divided by the speed of sound in soft tissue, which is 1,540 meters per second. So in this situation, we have the frequency being transmitted away from the transducer. It's intersecting with the blood vessel, and then this situation, the blood flow is traveling away from the transducer. So we already know that's going to be a negative Doppler shift. But you notice that the angle that's created between the ultrasound beam and the blood vessel, that's going to be the cosine that we're going to be talking about. That's the angle of inclination, and it's going to be the cosine of that theta. When making velocity measurements from Doppler waveforms, the Doppler angle should be less than or equal to 60 degrees. At higher angles, the error in calculating the flow velocity, it just becomes unacceptably high. In general, the smallest Doppler angle is going to give you the most accurate measurements. So as close as you can get to 0 is going to give you the most accurate measurements. But anything 60 and below is considered acceptable with traditional Doppler measurements. As you've seen in the last couple of slides, the velocity measurement is greatly affected by the cosine of the angle of incidence. So in this first image, you have the transducer transmitting the frequency, and as it intersects with the blood vessel, it is at a 90 degrees or at a right angle. If the cosine of 90 degrees is 0, then we know based on the Doppler equation that that's going to give us 0 frequency shift, which would be, based on that last chart, that gives us 100% error. We know that there's motion there and it's not being picked up because of the cosine of 90 degrees. Look at the next image. We've got a parallel flow to the transducer. That cosine of 0, which means we're parallel, is 1. So it's going to give you the most accurate measurement of the velocity of the blood in that vessel. At 60 degrees, we've created the angle with the transducer. This is a heel-toe approach. And with this, we've created 60 degrees. 60 degrees cosine is going to give us half of the actual velocity that's traveling through that blood vessel. But 60 degrees and under is considered acceptable by the intersocietal accreditation body. When we compare the differences of using Doppler within the abdomen as opposed to evaluating the peripheral vessels, one of the first things we have to note is the depth of the vessels. In the abdomen, there's much greater depth to evaluate those vessels, which means we have to use lower frequency transducers to get better penetration. When we do that, we lose some of the resolution. So with the peripheral vessels, they're going to be much more superficial. We're going to be able to use higher frequency transducers and get better resolution. Now with the abdomen, it's going to be easier to get parallel angles of intonation on some of the vessels. Let's say the celiac axis, and if we do a coronal approach for the renal arteries, then it's usually pretty easy to get a parallel angle. Now with the peripheral vessels, it's almost impossible to get parallel angle just by heel toeing or coming from a different approach. Majority of the time you're going to be using that angle of intonation, and you're going to be adjusting it to 6 degrees or lower in order to get a more accurate measurement. In the abdomen, we deal with a lot of motion. You have the patient's respiration, you have the peristalsis from the bowel. Peripherally, very little motion. Most of the time, if we include the carotids, then there can be some motion from respiration and also snoring. But in the lower extremities and the upper extremities, there's usually very little motion to have to deal with when we're trying to obtain good Doppler waveforms. If we place the patient in a right lateral decubitus position and we use the transducer approach from the left coronal or left flank, then you'll produce an image much like we have here. And you notice that the left renal artery is pretty much parallel to the transmitted beam from the transducer. So because of this, we can get the truest Doppler measurement because we have an angle of incidence pretty much 0. So we could use a 0 angle of incidence here, and we would be able to get the truest velocities moving from the origin all the way out to the kidney and the left renal artery. We can turn the patient into the left lateral decube and do a right flank approach and get much the same situation, even if it's just at the origin. And also, we could do this with patient supine and looking at the origin of the celiac artery. So there's several ways of manipulating the patient's body and the transducer approach in order to get the best angle of incidence, which we know is 0. When we discuss Doppler resistance, we know that there's low resistance and high resistance. Low resistance waveform is a result of the distal arterial bed, and with the arterioles, they can vasodilate. That means that they need more blood flow. They want it not just during systole, but they need it during diastole as well. So they get the integrated flow throughout the cardiac cycle. It's going to be elevated antegrade diastolic flow. This is typical for vessels that supply organs. So the celiac axis, since it is going to be supplying flow to the liver and to the spleen, stomach, it's going to have a low resistant waveform. High resistance, you get some vasoconstriction of the distal arterioles. So in this situation, you can get forward flow in systole, you can get a slight reversal in diastole with antegrade flow later in diastole. So typically this is found in vessels that perfuse the muscles of the extremities. So if we're talking about the abdomen, the distal aorta, as it is branching into the common iliac arteries, it's going to have much more high resistant waveform. Proximal aorta will have a lower resistant waveform. Not going to be as low as a celiac vessel, but it will be lower than the high resistant waveform you see here. So here's examples of the normal Doppler waveforms found in the abdomen. Aorta at the top, you see that the proximal portion of the aorta looks lower resistant than the distal portion of the aorta. And the reason being is the proximal portion, this is above the celiac axis. So the forward diastolic flow is because this aorta is going to give off a branch that is feeding major organs such as the celiac axis. So you get the lower resistant waveform in that proximal portion. After you've passed through the vessels that are going to be feeding the major organs, the distal aorta, it's predominantly feeding the lower extremities, which is going to be a much higher resistant vascular bed. You notice the celiac axis waveform is low resistant, but you still get a nice sharp upstroke, and then you get the forward flow throughout diastole, throughout the entire cardiac cycle. SMA is one of those that can be high resistant when the patient's fasting, but it will become much more lower resistant postprandial. So once the patient has eaten, then the intestines are trying to go to work and they need more blood flow to function correctly. So the SMA, which predominantly feeds the small bowel, will change from a high resistant waveform with fasting to a low resistant postprandial waveform. IMA is going to be more high resistant, and it pretty much stays that way even a postprandial. I'm going to look at the angle of intonation on these four images. If you start with the A image, we note that the angle of intonation is not parallel to the vessel wall. In this situation, the sonographer should steer the box in the opposite direction, and then that will steer the sound beam also, and then you would adjust the angle of intonation on the cursor to be 60 or less. B image, although they have adjusted the angle, the cursor angle, to be parallel to the vessel wall, if you look at the angle in the upper left-hand corner, it's highlighted in yellow because the machine's trying to tell the sonographer, wait, you don't want to do this, it's not going to give you an accurate measurement. 78 degrees is going to be grossly inaccurate. And so in this situation, once again, you would steer the box in the opposite direction and then readjust the cursor angle to be parallel to the wall and the flow. C image, once again, although they have adjusted the cursor angle of intonation to be parallel with the wall, it's still 72 degrees. Once again, you want it to be 60 degrees or lower because anything higher than that is going to be grossly inaccurate. In this situation, you would steer the beam in the opposite direction and readjust the angle of inclination to be 60 degrees or lower. D image is a perfect example of what we want. The box is steered correctly, the beam is steered correctly, and the angle of inclination with the cursor has been adjusted to be parallel to the vessel wall and to the flow. And in this situation, it's 60 degrees. This shows some examples of how changing the angle of incidence or inclination can grossly affect the velocity. So if you notice, when theta is 60 degrees with the first image, figure A, then the velocity is 124.5 centimeters per second. But when they've taken the theta down to 34 degrees, but if you look at it, it's not in line with the vessel wall nor with the flow, and so that changes the velocity. It underestimates it to 65.8. If you then take it the other way and you change it to 79 degrees, and it's still not lined up with the vessel wall, but it's well over 60 degrees, look at what it does to the velocity. The velocity is 286 centimeters per second. Since we are so dependent on peak systolic velocity to diagnose many of the vascular disorders that we see, it is extremely important to get the angle of inclination correct. It needs to be parallel to the vessel wall and to flow, and it has to be 60 degrees or lower. Anything below 60 degrees is fine. The closer you get to zero, the most accurate you're going to get the measurements of the flow through those vessels. So some of the pitfalls that we have to deal with when dealing with Doppler in the abdomen. Patients who are obese, especially if there's morbid obesity, it's much greater depth to try to evaluate those vessels, which makes it much more difficult to get good Doppler signals. As you can see in this image, we're dealing with bowel gas. Bowel gas just gives us that big fog that's very difficult to see around. Motion artifacts from the peristalsis and the breathing, another pitfall that we have to deal with in the abdomen. Congratulations, you did it. You have made it through the Doppler effects tutorial. Now you can access the instructional pages for this section, and then you can move on to the assessment.